My name is Michael Schechter. I am a pediatric pulmonologist. We're going to be talking a little bit about different sorts of respiratory problems that people with LGS can have, and I'm going to try and do that in just 15 minutes, 20 minutes. How do I have? It's going to be a little bit of a challenge, so I'm going to be a little bit provocative because I want to just sort of throw out some ideas for you all to be aware of. So first of all, as you all know, recurrent pneumonia is a common problem in people with neurologic problems such as LGS, but notice I'm putting recurrent pneumonia in quotation marks. So just to be clear, pneumonia is an infection that inflames the air sacs in one or both lungs. They fill with fluid or pus, but it's really kind of a blanket diagnosis that's given to people who walk in the door at the hospital or in the emergency room who are having some sort of respiratory distress. And it's not always a precisely accurate diagnosis. So here are a couple of examples of x-rays, and you can see on the left there's clearly this sort of big socked-in kind of abnormality. You don't need to be a radiologist to recognize something wrong there. You can see the x-ray on the right, which shows more diffuse, sort of funny-looking white squiggles, okay? And these are both patients who had true aspiration pneumonia. But there are two important risk factors to be aware of that put people at LGS at risk, and one of them is aspiration in general, but also we're going to talk a little bit about not just acute aspiration, but also chronic, sort of low-grade aspiration. And then there's this idea of poor airway clearance that I talked about a little bit at the workshop we did yesterday, and just the inability to mobilize secretions from the airway, and they get kind of stuck down there and cause all kinds of mischief. So those two basic risk factors are really what we're going to be talking about, what they lead to. They lead to pneumonia, but they also lead to other complications that are important for both acute episodes, but also to think about long-term strategies for prevention. So we're just going to go through a number of acute causes of acute respiratory distress in LGS. So number one, of course, is aspiration. This is what you're most familiar with. This is what you hear about. This is what you read about. You can have a large, during a seizure or something like that, there could be a large regurgitation of a large amount of stomach contents that get aspirated, and that gives you aspiration pneumonia. But aspiration can also occur as frequent small micro events. And it doesn't cause an acute episode, but it causes chronic airway inflammation that sets you up for bigger problems. So recurrent microaspiration causing airway inflammation. And so if you have that sort of inflammation, then small events like just having a cold, sort of a viral respiratory infection, can then lead to more severe respiratory complications, including bronchitis, which can be, again, mistaken for pneumonia. And in many cases, it may not matter that much whether you're dealing with bronchitis or pneumonia in terms of the acute management, but in terms of thinking about how these things can be prevented, it's really important. So these figures here show you, this is kind of what a normal airway might look like. This is what an airway looks like if there is chronic inflammation and chronic infection, bronchitis. The x-ray is more subtle, but these kinds of x-rays will often also be called by the radiologist pneumonia. So it's sometimes important to understand what really this x-ray looks like when we're clarifying this. So recurrent macroaspiration can be caused by basically two main problems. And one of them is gastroesophageal reflux, which most people think of as just maybe a cause of heartburn. But if stomach contents is coming up on a regular basis, sometimes it will occasionally sort of overflow back down into the airways. This is a particular problem in younger kids, but it can be a problem in older people as well. And gastroesophageal reflux is also important, especially in people who have G-tubes. There was some mention about some people with LGS may have a gastrostomy tube that they're fed with for several different reasons, and those G-tubes make you more susceptible to having reflux. Okay. The other part of it is swallowing dysfunction. Again, this is something that we see in particular in younger kids, but can be seen in older people as well who have neurologic dysfunction, that just in the normal act of swallowing, a little bit just goes down the wrong way. And again, it may not be enough to cause a big problem on a regular basis. You may see it as a little bit of a cough when they're drinking, but that can cause this sort of chronic inflammation and chronic bronchitis that then makes every subsequent event more problematic. Another potential issue that may be mistaken for pneumonia and is not exactly pneumonia is something called atelectasis. Now, atelectasis is sort of the internal collapse of part of the lung due to clogging of the airways with mucus. And the x-rays can often be difficult to distinguish from pneumonia. So again, in this x-ray here, you can see there's, again, that density that looks a lot similar to the x-ray that I showed you a couple of slides back of pneumonia. There are subtle findings there that somebody who's accustomed to looking at x-rays could look at and say, no, that's not really pneumonia, it's atelectasis. But atelectasis can also become infected and become pneumonia. Now, the thing is that people with muscle weakness or neurologic impairment are prone to atelectasis, again, because they are maybe not really able to cough very well, they're not able to clear their secretions very well, their breathing at baseline may be a little bit more shallow, so there's a little bit of a tendency for that sort of the clogging to occur. Then you put on that, again, you superimpose on that just a little bit of a cold, and it causes this extra problem. The other important susceptibility to keep in mind is people who have scoliosis may also be more susceptible to developing atelectasis in certain areas of the lung. Now again, atelectasis in itself is a problem. It can cause a decrease in oxygen, but as I said, it can also then be superinfected and cause pneumonia on top of that. So again, knowledge of the propensity to develop this is important to think about in terms of not just treatment, but also prevention. Bronchiectasis is another problem that can sometimes be seen, especially in people who have a tendency to have recurrent aspiration. So that these recurrent episodes of aspiration may cause permanent scarring and damage to the airways. So again, here in this picture here, what you can see is on the right, this is a normal branching of the bronchial tubes that you see in the lung. And if there are areas that have been especially prone to developing pneumonia in the past, the damage done to those bronchial tubes then leads to a chronic issue where they're never completely cleared of infection, they're never completely cleared of mucus. Okay, and so this condition, which is bronchiectasis, in and of itself can cause ongoing chronic problems and also exacerbations. Bronchiectasis can cause chronic cough, but exacerbations of bronchiectasis, which again will frequently occur in the context of viral infections, but may occur in the context of an aspiration episode, will then lead to acute respiratory symptoms. Here again, the chest x-ray changes can be difficult to distinguish from pneumonia. It'll often be diagnosed by the inpatient care team as pneumonia, but the important reason to recognize the presence of bronchiectasis is because, first of all, it needs to be treated with a more prolonged course of antibiotics. And second of all, because, I'm a little bit out of order on my slides here, and second of all, because there are chronic treatments that can be instituted to prevent these sorts of things from developing. So again, especially if you have a loved one who seems to be getting recurring pneumonia in the same area, the question is whether what's really going on is that they have this area of bronchiectasis that keeps on getting exacerbated. It's something to consider. You need a CT scan rather than a chest X-ray to diagnose that. And again, as I said, awareness and chronic therapies can prevent serious exacerbations. And then one word about asthma. Now, asthma in and of itself does not have a specific link to LGS, but asthma is really the most common respiratory condition in childhood and very, very common in adults as well. As many as 5 to 10% of all children have asthma. Okay, so by extension, I think we can assume that at least 5 to 10% of people with LGS, or at least children with LGS, also have asthma. Now, asthma can cause acute respiratory problems as well. These are not infectious per se, although the most common trigger of an asthma exacerbation is getting a cold. But the treatment is really more directed towards the underlying asthma than towards any specific infection. So asthma can cause chronic cough and chest congestion on a regular basis. It doesn't necessarily have to be cause wheezing, which is usually what we think about. Okay. Now, if asthma is present, our treatment is the use of these medications that are so-called bronchodilators. These are the medications that are steroids, which in the acute phase will be given systemically, either by mouth or by IV when somebody's acutely ill. But we also use it on a chronic form to prevent asthma exacerbations by using inhaled steroids. So this is actually a relatively easy condition to treat if it is potentially contributing to respiratory problems in somebody who has LGS. So in order to prevent, or to do the best that we can to prevent acute and chronic respiratory problems in LGS, first of all, we want to rule out chronic low-grade aspiration and eliminate it if it's present. Again, these sorts of low-grade aspiration and bronchitis is going to make any other event much worse, okay? So, and so particularly if a person with LGS has persistent noisy breathing or chest congestion, even when well, then aspiration, chronic aspiration is a consideration. Swallowing dysfunction can be ruled out with an X-ray swallowing study. And when it's present, especially in younger kids, it can be treated with dietary modifications. If it's severe, then sometimes you need to resort to G-tube feedings in place of oral feedings. Gastroesophageal reflux can be diagnosed clinically or with something called a pH impedance probe, although these studies are sometimes called normal in people who are having reflux-related symptoms. So sometimes it's really just best to empirically treat and see if it resolves the symptoms. Treatment would be with medications. In patients who are refluxing who have a G-tube, those G-tubes can be advanced a little further through the GI tract, and reflux will be prevented that way. And there's actually also an operation that's called a Nissen fundoplication that can stop reflux. Next, we want to rule out bronchiectasis and treat it if it's present. So as I mentioned, you want to do a CT scan if there's a consideration. It's best done when somebody is well rather than when they're sick, because inflammation and infection can sort of obscure the findings. And treatment of bronchiectasis includes more aggressive antibiotic therapy in general at the beginning of any sorts of respiratory symptoms, but also more prolonged antibiotic therapy in the context of an illness. In addition, there will be daily or as needed airway clearance therapies. We spent a little bit of time yesterday at the workshop talking about these various airway clearance therapies. If you missed it, you missed it. But they include chest physiotherapy, the high-frequency chest wall oscillation vest, various devices that are called oscillatory PEP devices, and then nebulization with hypertonic saline, which is just very salty water, to help loosen up the secretions, make them easier to expectorate. If somebody has decreased muscle tone, then we want to, first of all, rule out obstructive sleep apnea, which can also interfere with overall ventilatory response. And then we also talked yesterday about a technique called breath stacking to increase lung volume and increase the power of the cough, as well as something called a cough assist device. And then some of the other airway clearance therapy adjuncts that I talked about in the last slide would be useful there. And then if asthma is suspected, you should see a physician who's in a position to rule it in or out, pulmonologist. And then asthma rescue inhalers can be used as needed. And in people who have asthma, the use of inhaled medications with metered dose inhalers is just as effective as nebulizers, even in people who are not cooperative. So this makes it a little bit less onerous to be using these medications. And then we use daily treatment with anti-inflammatory inhalers if it's indicated. And then systemic steroids are used for acute exacerbations. So in conclusion, acute aspiration pneumonia is, of course, a significant cause of morbidity and mortality in LGS. And sometimes aspiration pneumonia is aspiration pneumonia, but other considerations need to come up. And frankly, aspiration pneumonia is difficult to prevent in the context of uncontrolled seizures. But not all acute episodes of respiratory decompensation are due to aspiration. Furthermore, aspiration episodes lead to more severe consequences when superimposed on underlying chronic conditions that I mentioned, such as chronic bronchitis, bronchiectasis, atelectasis, and asthma. And these underlying problems may require different treatment approaches and may affect the response to treatment. So perhaps more importantly, recognition of these underlying problems can be an effective way of preventing some of these acute respiratory episodes that people with LGS may be susceptible to. So thank you for your attention.